So the next speaker will be Professor Ben Cowling. He is head of the Division of Epidemiology and Biostatistics. His primary research focus is in infectious disease epidemiology. His latest research has focused on the modes of respiratory virus transmission, influenza vaccine effectiveness, and immunity to infections at the individual and population level. So over to you, Ben.
Thank you very much. So I'll spend a little bit of time talking about what's happened in Hong Kong, but first I will briefly go back to what happened in China from the early days. So our attention was alerted to COVID-19 in early January when we heard reports of the cases linked to the seafood market, and we were keeping a very close eye on the situation. On 22nd of January, we had the opportunity to go up to Beijing and meet China CDC collaborators and then work with them on a rapid analysis of the early data. And what we came up with together with them was published in the New England Journal of Medicine, looking at the early transmission dynamics of COVID-19. So the figure shown here is the early epidemic curve of the first 425 cases. And some of our important findings were the exponential growth in the early stage of the outbreak, with case numbers doubling every 7.4 days, and our estimate of a basic reproductive number of 2.2. What that means is, on average, one person who's infected will spread infection to 2.2 more people. And if that happens on a weekly basis, then initially the numbers are quite small, but they get larger and larger, as I'll come to in a moment. And our experience in that initial response was described in detail in a comment by Professor Gabriel Leung, called "From a Sprint to a Marathon," because initially we worked really, really hard to look at what was going on, and the public health measures were implemented really quickly in Hong Kong, but we think it's going to be a long battle against COVID for the coming months, even a year or more. And I just want to mention, before I get into the scientific results of our recent work, that the work we've done is really possible because of the long-term investment in the capacity for response to emerging infectious diseases. In our case, in the School of Public Health, we've been supported by commission grants from the Health and Medical Research Fund, that's from the Food and Health Bureau, back to 2004. So that's approaching 20 years of consistent funding for capacity to respond to emerging infectious disease threats in Hong Kong. And in the peacetime, in between emerging epidemics like H7N9, like COVID-19, in the peacetime, we've been working very hard on influenza and other infections as well. And we've had very good support from the university all along. I'll just show a couple of photos. This is the Department of Community Medicine in the Faculty of Medicine, Hong Kong U, back in 2006. It's about 60 people in the entire department. And in 2004, Professor Gabriel Leung, shown here, hired on the left, Stephen Riley and Joseph Wu, and then myself on the right, 2 academic staff on the left, and I was a postdoc in 2006. The 3 of us came in 2004 to start the infectious disease epidemiology team. And then a few months ago, this is our team photo, just the infectious disease epidemiology team. We now have about 50 people working full-time on infectious disease epidemiology. And many of these people have now diverted their attention away from their previous existing projects on influenza onto COVID-19 to support the research response in Hong Kong and also globally. So if I could get back to exponential growth, in the early stage of the epidemic in Wuhan, the case numbers were quite small. And I think we weren't really anticipating what was going to happen with exponential growth. And there's a story on this slide that you can read. But essentially, even when numbers are small at the beginning, if they're doubling with COVID-19 every week or every 5 days, perhaps, then you go 2, 4, 8, 16, 32, and it gets larger and larger and larger. And before long, there's 1 million cases in the world, and then 2 million cases, and it won't be long before there are 4 million and 8 million and 16 million and so on, because this kind of growth is very, very difficult to slow down. We've seen in other countries problems in getting on top of COVID-19. Many, many countries have followed the same well-trodden path. Here in the Financial Times graphic showing doubling every 3 days, which is even faster than what happened in Wuhan. I think some of the speed in case number rises in other countries is because of increases in testing capacity rather than truly increases in incidence. But certainly we've seen rapid growth in case numbers in many parts of the world. And this is already a month old. We've seen continued exponential growth in some parts of the world. In Asia, a little bit slower. And on the bottom right of here, going back a month, Hong Kong and Singapore and Japan doing very well, keeping case numbers down to a lower level and able to successfully suppress transmission and keep numbers at a lower level. In the early days of COVID-19, health authorities dug up their manuals on how to respond to emerging infections, and particularly epidemics and pandemics. And there are two basic concepts in responding to a pandemic. One is called containment, and the other is called mitigation. Containment is what we try for things like Ebola, and mitigation is what we try for things like pandemic influenza, where we think that we can't stop it or we don't want to make such an enormous effort to stop it. We want to slow it down to spread out infections over a longer period of time so that our health system can cope. For containment, that's the left-hand side of this table, we can accept some sporadic infections, but we want to keep the numbers of cases to a minimum. And certainly we don't want infections to be able to spread easily in the community. And so we'll have a number of public health measures that allow us to suppress transmission. Some of those measures are focused on cases. So they're specific measures. Firstly, we need to identify cases and then we isolate them so they can't transmit. And in some infections, we'll also trace their contacts and put them in quarantine. So if those contacts have already been infected, they can't further spread infection. We may also have some non-specific measures like social distancing in the community, like school closures, like working at home, and so on. So for containment, we'll have a mix of these measures. But of course, as we know in Hong Kong, all of these measures are difficult to sustain over weeks and then months and even a year or more. And there's major cost to them. On the right-hand side, mitigation is the other concept which would be used for the next influenza pandemic, most likely. If there's a concern that local numbers of cases would overwhelm healthcare systems, we'll try to spread out infections over a longer period of time. We won't use so many specific case-based measures because there may be too many cases to do testing of everyone, to do isolation of everyone, to do contact tracing for everyone. So we'll focus more on the community measures, the non-specific measures, if we're doing mitigation. So this is the concept, and this is from an updated guideline for pandemic influenza that my team wrote with the World Health Organization last year. So we explained the concept of mitigation. If you don't do anything, you have an epidemic like the one shown in green. And if you have a successful campaign of mitigation measures, you slow everything down, you flatten the peak, you spread out cases over a longer period of time. You might still have an excess of cases over the health system capacity, but the health system can be expanded to allow some excess capacity that wouldn't normally be available by deferring elective surgeries, by creating more space in hospitals, and maybe finding somewhere for milder cases to be treated outside the home. But in general, there'll be a small excess, but not too much. So in the early days of COVID-19, I think a lot of health authorities were thinking about mitigation, thinking about what might the impact be. And there was a very concerning report by Imperial College London, which explained that for COVID-19, instead of looking like this slide, actually what we're facing is something like this slide if we do mitigation. In other words, even a mitigated epidemic would substantially exceed the local capacity of the healthcare system. There'd be a lot of hospitalizations and particularly a lot of intensive care admissions beyond the local capacity. And that's why the UK changed from their herd immunity plan towards a plan for containment, because there'd be too many cases. It would be too much of a health impact to accept. And one of the comparisons I like to draw is for Hong Kong compared to New York City. In Hong Kong, we've had very effective public health measures since the very beginning, and we've been able to keep case numbers to a low level. If we look at New York City, a population slightly larger than ours, but not a lot larger, and similar in some ways. In New York City, there have already been 10,000 deaths from COVID-19. And so that could have been Hong Kong if we hadn't acted so swiftly and so effectively to stop transmission. And of course, in New York City, the epidemic is not over. It's still going on, and many more people could unfortunately die. And so I think we've done the right thing in Hong Kong to really stay on top of infections. The report from Imperial College that I mentioned was able to draw these inferences on what the impact of a pandemic might be, what the impact of a mitigated or even an unmitigated pandemic might be. And our results from our own team, led by Joe Wu, published in Nature Medicine, have very, very similar estimates to Imperial College London on the severity profile of COVID-19 infections, particularly the symptomatic case fatality risk of about 1 point something percent. What that means is, of all the people who get COVID-19 with symptoms, our estimate is 1.4% might be fatal. And that's really substantially higher than the case fatality risk for something like influenza. And we can see in New York City, 10,000 deaths already, when in a typical year from flu, they might only expect about 1,000 deaths. So more infections, higher severity of infections really adds up to much greater impact of an epidemic of COVID-19. And in another study that we published in Nature Medicine, I'll just show 2 of the 3 studies that we published in Nature Medicine. This is the second one. So in this one, we looked at presymptomatic infectiousness, which makes COVID-19 particularly difficult to contain. What we've found is the most infectious part for a person with COVID-19 is around the time their symptoms appear. And by the time 5, 6, 7 days after their symptoms have appeared, they're not very contagious anymore. And that means in Hong Kong, we're identifying cases typically 5, 6, 7, 8 days after onset in the past 3 months. What that means is if they're going to pass on infection, they've already done so in many cases. And so contact tracing is essential. There's been a lot of focus internationally about ramping up testing, but we have to understand that testing is not the only thing we need to keep on top of COVID-19. We need to test to identify cases, but then we need to get one step ahead of the virus by finding the people that may have already been infected by those cases, trace them, and put them into quarantine, either in a quarantine facility or at least home quarantine, so that if they have been infected, many will not, some will have been infected. If they have been infected, they're not able to pass infection on further into the community. So doing contact tracing and quarantine is getting one step ahead of the virus, and I think is really critical. So this is the current situation in Hong Kong. Just over 1,000 cases. The majority are imported from outside of Hong Kong. There's been relatively little local transmission, thankfully. We've been able to stay on top of it with quite a wide range of measures. So here's one summary of all the public health measures that have been implemented. The first row of public health measures are the travel-related measures, where initially travel was restricted and reduced from mainland China and then expanded to other affected areas. And then since late March, we've had a ban on entry of non-Hong Kong residents from outside of China. And that's really been very successful in keeping the numbers of imported infections to a low level. We saw in mid-March an increase in infections in people coming into Hong Kong that spread a little bit into the community and then was more difficult to get on top of. And I think the border control measures are going to be some of the most important measures going forwards in time. The second sets of measures, as I mentioned, are the case-based measures, the specific measures, increasing testing to the community so that we can pick up mild cases. Now we're testing everybody who arrives at the airport. In the future, we might also like to test people who are coming across the border from China, even who haven't been to Hubei province. We might like to test now people who are coming from the north of China, for example. And then the third set of measures are the community measures, including the school holidays, the working at home arrangements, the cancellation of mass gatherings, and then later in March, the restaurant capacity restrictions and some other measures as well. So Hong Kong's really done a lot. And this recipe for containment of COVID-19 and suppression of COVID-19 transmission is being looked at by many other countries now for their potential exit strategies to come out of lockdowns. Because in Hong Kong, we're one of the few places in the world that hasn't had to do a lockdown to deal with COVID-19. In addition to all of the government measures, I would also like to mention the changes in people's behaviors as being really important. For example, people voluntarily choosing to avoid going to crowded places, voluntarily choosing to wear face masks, even from an early stage of the COVID-19 pandemic. Even back in January, we saw as many people wearing masks as they did during SARS, which was 75%. And now in February, March, 99% of people wearing masks in public, particularly important, I think, in public transport and in crowded areas, because it really limits the opportunity for the virus to spread in the general community. One of the ways which we can identify a very substantial effect of the non-specific measures for COVID-19. So I mentioned before, there's specific measures like testing, isolation, contact tracing, quarantine, but we also have the non-specific measures, the social distancing measures. We can see how important those have been because there's a very drastic reduction in influenza transmission in Hong Kong. The flu season was on the way up and it basically stopped dead and went right away very quickly after Chinese New Year. We saw a 44% reduction in influenza transmission, which is much more substantial than the reductions we tend to get from school closures, 15% reductions in transmission from school closures in previous years. So I think that's really important. And it's a sign of all of those public health measures, working at home, avoiding crowded areas, wearing masks, improving hygiene. All of those measures together had a really big effect on influenza. So if we have the non-specific measures and then for COVID, we have the specific measures as well, that shows how we've been able to stay on top of things. We've been tracking the transmissibility of COVID-19 in Hong Kong over time, and we have a dashboard on our School of Public Health website for the public to keep track. So there's two things shown here. The first one at the top is the reproduction number. I mentioned at the beginning of the talk in Wuhan, at the early stage of the epidemic in Wuhan, we estimated the reproductive number was 2.2, meaning that one person on average spreads to 2.2 more, and that happens on about 5 to 7 day time cycle. So it goes to 2 and then 4 and then 8 and then 16 and so on, keeps going up exponentially. In Hong Kong, we've been able to keep the reproductive number at 1 or even below 1. There was just a blip when it went up in late March. But we've been able to keep the reproductive number at 1 or below 1, I would say, for almost all of the past 3 months. And I think that's been really, really because of effective public health measures. We've had to stop tracking the reproductive number now because the case numbers are so low. When there's no local cases, there's no reproductive number to estimate. But we can tell because there's no local cases that the reproductive number must be low. So we'll pick this back up again if there is a second wave in Hong Kong starting in the coming months. We'll resume estimating the reproductive number again because it's a really useful way to keep track of the situation and have situational awareness. So what's next? I think the suppression measures are going to continue to some extent. We may relax a little bit, but we need to be nimble so that if the case numbers come up again, particularly after imported cases are detected, we're aware that there is opportunity for infection to get into the local community from time to time. And so there could be sporadic local infections and outbreaks. And we need to be nimble with the public health measures so that if we relax some measures now, we're ready to put them back in place if the numbers of cases go back up again. Because I don't think we can sustain very, very strict measures for the next year, but probably we can have a relaxation when the numbers are very low. And then if the numbers come up again, we have to tighten them again for a month or two to get the numbers back down again. And we need to be very, very alert. So Professor Yoon mentioned in the previous talk, we need to increase the testing capacity so we can pick up all of the mild cases that might be occurring in the community. I think that's critical. Need to be able to do a lot more testing. And also if there is to be another outbreak in the future, in the next month or the next few months, we need to be ready with the capacity to do contact tracing to find those people that might have been infected before their symptoms appear so that we can get ahead of the virus and get ahead of transmission. And the last point, I think the border control measures are really critical to keep the imported infections at a low level. We can look at relaxing the border control measures to places that are unaffected, like Macau, like other parts of Asia, Australia and New Zealand, perhaps in the future. But I think we need to keep the border control measures quite tight for quite some time to come. Otherwise, we will have more imported infections. And then as we saw in March, there's opportunities for that to get into the community and start outbreaks. So 3 things that I think could be needed. Firstly, for our own research area in epidemiology and public health, we're looking at which are the most important components of the success in suppressing COVID-19 and which measures can be relaxed first. We're thinking about school closures. We know children are not so affected as other age groups in COVID-19. But of course, with other respiratory infections, children really are drivers of transmission for flu and for other common colds infections. So is it safe to let children go back to school or not? What's the contribution of school closures to the success of suppression? What's the contribution of the restaurant measures, the working at home, and so on? That's really our active research right now. So we can say what's the most critical parts of suppression measures? What are the most important measures? The second thing that we're thinking about is how can we identify people who are infected before their virus shedding appears, before their symptoms appear? Is there any way, are there any biomarkers that we could use to identify people who've been infected, maybe when they arrive at the airport or when they arrive at the border, before their virus appears? At the moment, we're doing PCR testing for the virus, but we know there's a latent period and some people will be negative for virus at the border, but then days later, a week later, they'll be positive because they've been infected, but they're in their latent period before the virus really appears in detectable quantities. And then the third issue, I said before that contact tracing and quarantine are really, really important to get ahead of the virus. But how can we do contact tracing more efficiently? In other countries, they're looking at the use of mobile phone apps so that people can record their contacts, even their casual contacts with people that they don't know. Because when we do contact tracing, it's often done by interviews. So a case will be asked, who have you met? Where have you been in the past few days? Maybe since your symptoms appeared. And then try and track down those people. And it's not easy to identify transient contacts. Who did you sit next to on the bus on an hour journey to work? You don't know. They don't know, and it's very difficult to find out. So if we have mobile phone apps that could identify those kind of casual contacts, that could really help with contact tracing and allow us to use more of the specific measures and less of the non-specific measures to keep COVID-19 under control. The last thing, we understand that serological studies are really critical. So we're planning seroprevalence studies in healthcare workers, in the community, and in high-risk professions over the coming months and the coming year or more. We know that right now in Hong Kong, the seroprevalence will be very, very low because there's been so few cases in Hong Kong. But in the coming months, we don't know what's going to happen, and we want to be ready to identify if there is spread in the community, to what extent that spread is occurring. And then after vaccines become available, we can also use these kind of studies to look at population immunity over time. We've been working on population immunity for some time already. We have projects on population immunity for influenza, and those are now expanded to population immunity from COVID-19, not only because of immunity, because of natural infections, but in due course immunity because of vaccination. So I'll finish there. This is, of course, collaborative work with Professor Gabriel Leung, Joe Wu, Wu Peng, Eric Lau, Kathy Leung on this slide, and many others that I showed in the earlier photo in the School of Public Health.
Okay, thank you, Professor Cowling. So questions are still coming in. Let me ask the first one. Usually people, when people describe how contagious the virus is, they use a number called R0 value, right? So in the specific case of Hong Kong, if you look at the cumulative number versus, the timeline, you have this sigmoidal curve. And the turning point, obviously, is what we call the second wave, is when these Hong Kongers from overseas coming back. So in terms of that, there is an intrinsic component as well as an extrinsic component, right? The intrinsic component really describes how contagious the virus is, but then the extrinsic component is more to do with the government policy, travel ban policy. So in your analysis or your type of analysis, how do you factor out these two components?
Got it. So the R0 that you mentioned is the intrinsic capacity of the virus to spread in a population. It won't be the same everywhere. It'll be higher in Hong Kong and in New York City than it would be in a rural area or a lower density area. So we think that the R0 in Hong Kong could have been 2.5 or even more because it's so dense, But of course, with the public health measures, we can reduce that even from the beginning. So we, instead of having R0, we had the reproductive number of about 1. So that must be a 60-70% reduction in transmissibility because of the public health measures, because of all the effort that we made in Hong Kong to keep transmission at a low level. And that's really, really an indication of how effective all of our measures have been. Because if we hadn't done anything, we certainly would have seen a lot of infections, and we'd be in the position now of probably New York City with hundreds of thousands of cases, 10,000 deaths, and still a long way to go.
Okay, thank you. Now, this is one from an audience called, I think his name is Terrence. It's about contact tracing that you talk about towards the end of your talk. His question is, you mentioned about using an app would be quite an effective measure. So his question is how to get people to download it, install it, and what about privacy and cybersecurity concerns?
Yeah, no, that's exactly all the questions that many countries are now dealing with. So in China, of course, they have the capacity to do exactly these kind of things because they are able to track people's movements. They have facial recognition technology in big cities. And so they know where people have been all the time. But in the other parts of the world, that's not possible. So we would need a voluntary effort for people to install these apps. And of course, there are privacy concerns. Of course, people wouldn't like their movements to always be monitored and the data to be collected. So that's really something we're thinking about. How can we enable contact tracing to be done for public health purposes, but at the same time protect people's privacy and, you know, and safeguard information security and so on. So that's really the challenge right now, is thinking about that. And I know many countries are dealing with the same questions.
Okay, this is a question from Pan Gao. He asks, do you think a screening covering the population is necessary?
I don't think screening everybody is necessary, but certainly what we'd like to do is screen a random sample of the population so that we can see if there's any evidence of spread in the community that we might have missed. But at present, I think the rates of infection would be very low. There's 1,000 confirmed cases that we know of. There may well have been some other infections that have not been picked up, but it would not be a large number. And in terms of testing for the virus in everybody, I don't think there's any need for that right now, but we should be in a position that we can test anybody with mild respiratory symptoms or mild symptoms that could be COVID-19. And that could involve potentially thousands of tests at some point in the future. So we need that capacity to be there so that we can detect all the infections that present with symptoms. But I don't think we need to screen the whole population.
Thank you. Another question, what is your comment on Sweden's very different approach to reach natural herd immunity, which may cause much less economic damage?
So everybody in the world is very aware of the economic damage caused by lockdowns, caused by control measures against COVID-19. Even in Hong Kong, we have economic damage from the measures that are not as drastic as lockdowns. When we look at what could happen in Hong Kong if we allow herd immunity to build up, meaning if we allow up to half of the population to be infected, maybe by spreading out infections, protecting the most vulnerable, but still enabling COVID-19 to spread, I think we'd see a very, very significant health impact of infections. As I mentioned, in New York City, 10,000 deaths already, and there's some comparisons between Hong Kong and between New York City. So I don't think in Hong Kong we'd like to be in the position of seeing people dying from COVID, particularly if the virus was able to get into elderly homes and institutions. We've seen how devastating it can be in those kind of settings. And in a place like Hong Kong, it's very difficult to stop that from happening. In other countries, maybe they can shield the most vulnerable. But in Hong Kong, we're all living very close together, and it would be very, very difficult to shield the most vulnerable in our populations.
Okay, this is a question from a student, Zhu Lan. The question is how to look at the COVID situation in developing countries, particularly Southeast Asia.
Yeah. It's really a massive challenge. In Hong Kong, we're able to do these non-specific measures, working at home, closing restaurants or reducing capacity, sorry, closing bars, having restaurant measures, closing those facilities. In developing countries, many of those measures are not possible. And so suppression itself may not be possible. At the same time, they don't have capacity for doing a lot of testing, don't have capacity for contact tracing and quarantine. So I think in many developing countries, they're going to have to look at mitigation measures rather than containment and suppression measures. and just slow down transmission as much as possible, spread out the epidemic as much as possible. Because if they really go for prolonged lockdowns, it's going to be devastating to their economies, which are more vulnerable to the impact of those kind of measures than maybe we are in Hong Kong, where we can have working from home, we can have some of these other measures because we're such a developed economy. It's more feasible for us to achieve what we've achieved in suppression.
Okay, the last one, because we are really short of time. From Jessica Liao, why are there differences in the death rate between regions?
I think most likely the differences in death rates among confirmed cases are just because of different testing practices. So, for example, in the UK, they won't test any mild cases. They only test people if they need to go to hospital. And so, of course, the death rate among confirmed cases would be higher than in a place like Hong Kong or Singapore, where we pick up even the mild cases. And so the denominator of confirmed cases includes many, many mild infections, and then the fatality rate will be lower. We know that in reality, the severity of infections is most likely quite similar everywhere in the world, maybe minor differences, but it's most likely very similar. And so I think those differences in confirmed case and confirmed deaths is just because of changes in testing practices.
Okay, thank you very much, Professor Cowling.